university hospitals. I'm a hospital epidemiologist and attending physician in clinical infectious diseases here in Geneva, Switzerland. We're going to talk about infection control and COVID. I have 5 slides for the beginning, very brief introduction, and then we may have about 10-15 minutes for Q&A. So when we talk about infection control and preventive measures to protect healthcare workers and patients, we are facing multiple challenges. First, of course, our current evidence base is mostly based on the experience and the literature of influenza and the first SARS epidemic and MERS-CoV that happened a couple of years ago. We're facing multiple myths and beliefs and fake news. Unfortunately, there is even conflicting the guidance by local, national, international guidelines and guidance documents. Then, of course, we always have to address local needs. There are certainly supply chain issues in many low and middle income countries. There are also, of course, very pragmatic needs by healthcare workers. And then once you take decisions, always you have to think about good communication and coordination when it comes to making sure that your healthcare workers adhere to local standards. So just an example from my own institution here, a patient was recently operated in our hospital. The patient was screened prior to surgery and was detected to be negative. So there was no suspicion of COVID. There was no virologic evidence of any kind of incubation. And you can see all the 3 healthcare workers have different attitudes here in the OR. One is wearing a N95 respirator. Here, a colleague is wearing both a surgical mask and a buff N95. And here you have another OR technician just wearing the usual surgical mask. That this, of course, would be the correct attitude. And you can see that this colleague is looking very bestranged at her colleagues because she doesn't understand what's going on. So this is unfortunately the situation, what's happening in many institutions around the world, that there is this kind of discrepant behavior. Just to make sure that everybody knows, SARS-CoV is transmitted mostly by droplets, not by airborne transmission. So it's within 3 feet. That's why we, as you know, we recommend droplet precautions and not airborne precautions on a routine basis. However, there are specific preventive measures to be undertaken if you have aerosol generating procedures like intubation or non-invasive ventilation. And just to make sure that everybody got the main message, so the PPE and preventive measures that are normally recommended is droplet or contact isolation and contact isolation in private rooms. If possible, when you do the swabbing, you implement airborne and contact precautions. And then also something that is, of course, mostly for high-income countries, if possible, negative pressure rooms for all aerosolizing procedures. But even in Switzerland, we cannot comply with this kind of recommendation. So these recommendations are based for us on recommendations by WHO and also our national guideline committee, which is called Swiss NOSO. In a nutshell, this is my last slide. This is from a North American institution. The main messages are that we should always comply fully with the hand hygiene and the use of alcohol-based hand rubs. If possible, follow the local PPE guidelines, avoid touching your mask, use respirators, keep some distance. If possible, disinfect your work surfaces. And of course, if somebody gets sick, if possible, this person should not be in touch with the patients. Okay, that was a short introductory presentation. And now, of course, there are lots of questions, I guess, for the local settings in low and middle income countries, which of course are completely different from what some national guidance documents in the Northern Hemisphere recommend. Thank Over.
Thank you very much, Doctor. So, if there are questions from the audience, they can share and we can point it out. But my question is regarding the use of PP. What do you think of how long should you use an N95 mask in resource limited areas? Is there a possibility of reusing N95 masks?
Yeah, that's a very good point. Of course, even here in Switzerland, we had moments where we had a lot of shortages of N95 masks. So we allowed them to wear the same masks for the whole day shift. And then we have now currently some protocols underway of even sterilizing N95s and reusing them, which is not anymore required. We have enough N95 mask supply here. But definitely what's very important is also not only the time that you wear these masks, but also the handling. So probably some healthcare workers, they get contaminated just by handling, by taking off their mask without using proper hand hygiene. So therefore, I think that in very resource limited settings, of course, if you have only one N95 respirator for 2 or 3 days for a healthcare worker, it's something that may become reality, and you have to adjust to this reality. But still, an important message is that, of course, healthcare workers always have to disinfect hands after handling these N95 respirators. But here now, we use N95 respirators more frequently during a shift, a nurse shift, because we have enough supply. Over.
Okay. Thank you very much. So maybe one more question. Due to shortage of these PPs, maybe there are these locally produced PPs like usually made of this what we call beans, plastic beans.
Yeah.
So is there any evidence that they are protective in regard against viruses, or just extrapolating it routinely?
So most of these handmade, or let's say more recent masks, of course, they protect more other people. If you are incubating and in the pre-symptomatic stage, it is still quite plausible to say that they protect the other people, the other healthcare workers in your environment, or patients who are COVID negative. But most of these devices may not be optimal in protecting yourself in case you're handling high-risk procedures like non-invasive ventilation, etc. But I don't know specifically about the mask that you're mentioning. I don't know exactly the performance and the kind of evaluation that has been done so far. So that's why I cannot provide you any kind of detailed input.
Yeah. Maybe one more question. In people who are handling these COVID-19 patients, I mean, how protective is to use locally made these beans, plastic?
I don't know. I cannot really say anything that there is no evidence about, but I would say it's an incomplete protection for, if you mean these kind of plastic shields, then this is not comparable to the N95 protection. I mean, the N95 plus goggles, that's quite sure that these kind of PPE will protect you sufficiently.
Okay. Thank you very much. From the audience, if there are any questions.
Is there anybody there?
Yeah, it is on YouTube. We are transmitting from Zoom,
okay.
So people are watching us on YouTube.
Okay.
Yeah, so I'm waiting if there are any questions.
You are working in Addis Ababa?
No, I'm working in Jimma University. It's a medical center. It's one of the COVID-19 centers in the country, actually.
Okay. Do you have enough capacity to also test patients to see whether they are positive or negative?
Yeah, we have enough capacity for that.
Okay, that's good, because that's of course one of the key challenges in low and middle income countries, whether you have enough capacity to test and see who is positive, who is negative. Do you have also some cohorting facilities so that you can separate COVID positive from COVID negative patients in different wards or even buildings?
Yeah, we do have different settings for that. We do have these quarantine centers where we keep suspected people before testing, before the confirmation. We have also isolation center and a treatment center. So specifically designed here, like at 3 places, we have treatment center. So this will serve for around 20 million people which are in the southwestern part of Ethiopia.
Okay.
So we are planning to do that. Also, there are also different treatment as well as quarantine centers in different zones.
Excellent. Okay. And what's your local experience at the moment? Do you have still increasing numbers, or did you already manage to stabilize?
The numbers are tricky actually. It's not. We can't say it is increasing or decreasing, but more of I think it is stable. We have also a record of 0 up to maximum of 5, but the number is erratic. It doesn't follow a particular pattern.
Okay, I understand.
Yeah, we are having until now. I think we are having 124 patients who are confirmed to be COVID positive.
How many?
124.
Oh, okay.
Today, I think 126 today.
Okay, that's still manageable, yeah.
Yeah, still manageable, yeah.
Did you see any kind of attacks on? Because I guess you have quite a lot of Chinese who are still in your country. Did you see any kind of hostilities against the Chinese people who are still in your country, or is it no kind of violence?
Initially, there was a few reports of violence against these people. Now, I think through lots of campaigns and awareness creation, I think things are not happening anymore.
Okay. So, were there any questions now from the audience?
I didn't receive any question till now.
Okay.
Maybe. I think we are also running out of time.
Here I can see now. I can see there is a question. Some people recommend surface disinfection. What is your opinion? So, at the moment, the surfaces are not really the main problem. I think that, of course, if you can just use regular disinfectants, for instance, for keyboards, if you have a cohort unit where you have patients who are really contagious, they are even undergoing non-invasive ventilation, then we just recommend the use of regular disinfectants to clean, for instance, the computer keyboard and these kind of things. But at this stage, for me, it's much more important to have a very good supply of hand hygiene products like alcohol-based hand rub solutions, which, of course, as you know, can be produced locally. You don't have to spend a lot of money to buy them from other countries and companies. I know that many African countries now can produce alcohol-based hand rubs on a local base. So that's for me much more important than this question whether we should take very specific precautions for the environment. Yeah.
Okay. There is one more question, Doc, if you see, what is the probability of COVID-19 that it will come back after we control the current pandemic?
It's a very good point. I've become very careful about predictions, but I would say that it is very, very likely that we will see another wave, at least in the northern hemisphere, that there will be a bounce back in the fall. and I'm quite pessimistic that this virus will not disappear just within 2 or 3 months from our planet. Unfortunately, I think we have to live with it at least for the next 12 to 18 months, but we will learn quite a lot. That's maybe the final optimistic concluding remark from my side, that it's spectacular how quickly now we are running many studies and the evidence base is growing every day. So I guess by fall, once the virus gets back to the northern hemisphere in the fall and the winter season, we are much better prepared than we were now. So that's maybe a little bit of a hope, but I don't think it will completely disappear like the SARS-1 in 2003, which was much less contagious and had a lower viral load. So it is unlikely that we will see the same scenario like we saw 17 years ago with the first SARS outbreak in Asia. Over.
Okay.
Okay.
The other question? Okay. There are a few more questions. How often do you test patients before declaring them negative is the other question.
Yeah, so that's a good point. In Switzerland, we don't follow the WHO guidelines that all patients need to be swabbed twice. We are much more focused on some sound epidemiologic reasoning. So in general, most of the patients are declared cured between day 12 and day 21. In certain rare instances, we do a follow-up screen, but otherwise we do not follow the WHO guidelines, and I cannot see why low and middle income countries have to follow this kind of extreme guideline, especially when you have limited resources available. You should much more focus on the detection of patients at the beginning of their disease than at the end, where most of those people don't cough anymore, and so their likelihood that they are really contagious becomes very small.
Okay.
So the last question, and then I have to leave. Unfortunately, I see, why do we see slow epidemics in Africa in spite of the crowd and low health services? So very good question. This is maybe a mix of different explanatory determinants. One could be that, of course, in Africa, you still have a relatively young population. So we know from many studies now in Europe, North America, and Asia that people below 50 years of age may not have a very severe disease. So it could be that you may have lots of younger people who are not necessarily sick. Second, of course, there could still be a detection bias because in many African countries, you don't have the same capacities to screen like we have now in high-income countries. Third, it could still be, in some African countries, it could still be a question of the climate. I am not so convinced about colleagues saying that this coronavirus is transmissible and the same kind of contamination happens in warm, cold, dry, humid, etc. Climate. So I think there could be still maybe a small part of this explanation could still be related to some climatic factors, but who knows? So we have to wait for another few months to see really what's happening in Africa. Okay, good. So I will have to leave now. Thank you very much for participating in this interesting webinar, and all the best to you, and hope that you stay well and safe. Thank you for joining.
Thank you very much. Thank you very much, Doctor.
Thank you. Bye.
Okay. Bye-bye.